epidermal thickness, and also it could recruit the inflammatory cells such as the neutrophils, lymphocytes, and resulting in the growth arrest and premature differentiation apoptosis of a basal keratinocyte. And also in some cases, it could increase the susceptibility of the infection superimposed. Next, please. So from this table, you could see that in addition to the skin toxicity, mainly the acneiform eruption or the papulopustular rashes, the EGFR inhibition could also cause a dry skin or cirrhosis, dermatitis, or the color change of the skin, causing the hyperpigmentation or the pruritus or the itch. And if the patient also receive the radiation therapy, the combination of the EGFR inhibitors and the radiation therapy result in the radiation dermatitis as well. And also the soft tissues around the skin or the epidermis, including the nails, the hairs, or even the eyes could be affected from the EGFR inhibitors. Next, please. So from this graph showing the intensity of the dermatological adverse events, including the acneiform rashes, which could be happening as early as the first few weeks of treatment, and also the dry skin, the hair change, and the nail change. And along with the intensity of these adverse skin reactions, if we apply the prophylactic or the reactive skin toxicity management, these reactions could be controlled and even subside after the completion of therapy. Next, please. As you could see here, the severity of skin toxicity depends on the skin types of the patients, either the skin phenotype or the pre-existing skin condition of the patients, and also from the environmental factors such as the sun exposure or the concomitant radiation therapy. Next, please. So from the clinical studies using the panitumumab, either as a single agent or in combination with chemotherapy, the toxicity of the skin could happen in more than 90% of patients in all grades of skin toxicities in combined, mainly the rashes and the acneiform skin eruptions. But the grade 3 skin toxicities happens around 1/3 or 1/4 of the patients, and less than 1% of patients develop the life-threatening toxicity. Next, please. So in addition to the common acneiform eruptions, other forms of skin toxicity could happen, as you could notice from this table, and also the superimposed infections of that area, including the paronychia, or the eye disorders, including the conjunctivitis or phlebitis, could happen as well. However, the life-threatening skin reactions, such as the Stevens-Johnson syndrome or the TEN, is pretty rare as the skin toxicity of the patient. Next, please. So from the clinical trials using the panitumumab, the size or the area of skin that's mostly affected are the face, the upper chest, and back. But some patients also developed some rashes on their extremities as well. And the median time to first symptom of skin reactions to develop was around 10 days, probably around 10 to 14 days during the first 2 weeks of treatment. The median time after the last dose of panitumumab was stopped, the median time to the skin reaction to be resolved was around 4 weeks or around 1 month. And in some patients, as being said, some infections, superimposed infections could happen as well. Next, please. So as the recommendation for the dose modification of patients receiving panitumumab, if the patients developed grade 3 or more of the skin or the soft tissue related toxicity, or even the intolerable reactions, it has been suggested to withhold the treatment for 1 or 2 doses until the symptoms are recovered. And when the toxicity grading resolved to the grade 2 or less, then the healthcare provider or the physicians could resume the panitumumab treatment with the full dosage. But after the resume of the panitumumab, if the skin reactions occur again, it has been suggested to do the dose reduction from 100 to 80% of the original dose, and then if the AEs occurs again, to the 60%. And when you go down to the 60% of the full dosage and the skin reactions still occur with the grade 3 or more, has been suggested to discontinue the panitumumab permanently. Next, please. So from this study, I'd like to share with you on the patients from my own practice that I have had experience using panitumumab, mainly with the chemotherapy, the irinotecan, as the third-line regimen of treatment, and this based on the healthcare reimbursement policy of our country, that the patients whose the civil service or governmental base could get the reimbursement of the panitumumab as the third-line treatment. And as you could see from the columns of AEs within parentheses, the maximal grade, all of my patients developed skin reactions, mainly the rashes. Some had a paronychia with the grade 2, and subsides after the skin reactions management. So in terms of the response or the efficacy of this treatment regimen, around 50% of patients experience the clinical benefits, meaning either the stable disease or some partial response. And I also have had the opportunity to use the panitumumab with the anti-RAF and anti-MEK in 2 patients, patient number 8 and number 9, who had the RAF mutation, the BRAF of V600E. Next slide, please. So I'd like to share the patient number 9 cases with you. So this was a 52-year-old female patient harboring the BRAF of V600E mutated metastatic adenocarcinoma. So her metastatic sites include the single brain metastasis, which she underwent the craniectomy with the tumor removal. And at the same time, she also had her metastatic lesions in her lungs, liver, and intra-abdominal lymph nodes. So at that time, we had the compassionate user program from the pharmaceutical companies giving the RAF inhibitor as a dabrafenib and the MEK inhibitor as a trametinib to the patient for the first 2 months of treatment. And the patient and her family decided to go on that regimen. So this RAF MEK inhibitors in conjunction with the panitumumab were given to the patients as a first-line treatment, and she experienced and she achieved the partial response. Next, please. However, after when she came back to the clinic, she developed this grade 2 acneiform rashes on her face and the upper chest and upper back. At that time, she did not receive the prophylactic or preemptive skin toxicity management. So I consulted, I sent her to be seen by the dermatologist in our hospital, and she was given a topical steroid, a topical antibiotics. But however, after 2 to 4 weeks more of the treatment, as you could see from the lower photo, that she developed these prostate lesions on her face and even her back and on her extremities, with some suspected bacterial or superimposed infection. Next, please. Her dermatologist at that time performed the skin biopsy for her, and on the left hand side for the lower and on the right for the higher magnification of the skin biopsy, you could see that the epidermis and the superficial layer of the dermis of her skin sections were disrupted, and the fibrins and the cell debris replaced on that area, as well as the inflammatory cells infiltration, mainly the neutrophils, histiocytes, plasma cell eosinophils. However, there's no evidence of the vasculitis or the immunofluorescence panel showed a normal pattern. So from the pathology diagnosis, this is also with the infection superimposed. Next, please. So we came to the recommendation for the management on this case. She received the anti-EGFR inhibitor, the panitumumab, with anti-RAF and anti-MEK, and that might be one major reason why she developed this severe grade 3 skin acneiform rashes. Next, please. So the general recommendations for the management of the skin or soft tissue toxicity from the EGFR inhibitors include the appropriate assessment, the suggestion of the emollients or the moisturizers, sun protection agents, and also the patients can do the bath or shower oil. Next, please. So for the appropriate assessment, the healthcare providers should evaluate the skin toxicities carefully, and there might be some pitfall or the underreport on the true grading of the skin reactions, since the grading that we have been using right now is a CTCAE, which use the percentage of the BSA affected. And if the lesions are more than 30% or more, that could be graded as a grade 3, and that should be cautious in some patients who develop the toxicity only on the one body region, which is not more than 30%. So you have to keep in mind on that as well. Next, please. And also the other thing to be considered when assess the toxicity grading of the skin reactions would be about the difference in the ethnicity, race, or the skin color. Since fair skin people may develop more severe skin reactions than the darker skin individuals. And also in darker skin individuals, the skin reactions may not be clearly visualized until the damage is more severe. Next, please. So the general guidance for the agents that should be used for the patients would be the moisturizers, or especially after the washing, bathing, or showering of the skin, and apply the moisturizer and also the sunscreen in the sun exposure area before going out. Limit or try to avoid the direct sun exposure, and also if some acneiform rashes are developed, avoid to use the greasy creams to the face and neck at that affected area. Next, please. So for the treatment recommendation for the mild, moderate, or severe, or resembling the grade 1, 2, 3. For the lower grade of grade 1, you can use the topical and antibiotics for the papulopustular rashes. And when the rashes get more severe in grading, the oral antibiotics, either the minocycline, as being shown on this slide, or the doxycycline could be prescribed to the patients as well. And to alleviate the itch or the pruritus symptoms, the antihistamine, the loratadine or hydroxyzine could be prescribed. If the patient develops the superinfection, mainly the Staph aureus, then add the topical antibiotics or the oral antibiotics accordingly. Next, please. Okay, so showing on this slide, if the patient develop dry skin, at the beginning, we recommend patients to use the moisturizers, emollients, and for the eczema, the topical corticosteroid. If the skin cracks happens or occurs, the salicylic acid ointment could be prescribed as well. In some patients who developed the overgrowth of the eyelashes, or the term trichomegaly, then we suggest patients to cut or cure the eyelashes, and also the other supportive care measure. Next slide, please. Okay, so nails care carefully, and wear the protective clothing when going outdoors. Also the gloves or the appropriate footwear or a hat to avoid from the direct sun exposure. Next, please. So there are two principles of management of the skin toxicities here as being shown. You may use the conventional, the old-fashioned, the reactive management, where at the beginning we suggest the patients to use the moisturizers or the sunscreen, and when the skin reactions occur, we can prescribe the oral antibiotics or the topical steroid. But on the right hand side of the table, the other approach is to prophylaxis this skin toxicity to happen. And these include the skin moisturizer or sunscreens regularly, probably 2 times a day, in the morning and at the night time. Apply the topical steroid cream, and also give the oral antibiotics just for the prophylaxis of these skin reactions to happen. Next, please. So for this lady, after the final diagnosis of the pathology report showed that she has the vasculitis. It's the drug eruption with the bacterial superimposed. She received the oral antibiotics, and that was changed from the prior doxycycline to the dicloxacillin, as well as the topical the emollients and other supportive care. And her skin condition was improved after 2 to 3 weeks after that treatment. And the most important thing at that time, when these reactions developed, we stopped all 3 agents of the anti-cancer regimens, both the RAF, MEK inhibitors, and also the panitumumab. Next, please. So at the last half, the second half of my talk, I would like to share with you the two studies addressing the importance of this preemptive skin treatment compared to the reactive skin treatment in patients treated with panitumumab in metastatic colorectal cancer. Next, please. The first study entitled STEP, which stands for the Skin Toxicity Evaluation Protocol with panitumumab, and is a phase 2 open-label randomized trial. Next, please. So this is the treatment in the second-line setting. So patients with metastatic colorectal cancer disease who had the disease progression or unacceptable toxicity from the first line of fluoropyrimidine and oxaliplatin-based chemotherapy were randomized to have the second-line regimen of treatment with panitumumab plus either the FOLFIRI, and in that case, the dosage of panitumumab was 6 milligrams per kilograms every 2 weeks, or panitumumab 9 milligrams per kilograms every 3 weeks, plus the single agent irinotecan. So this depended on the investigator's choice. The patients were randomized to receive either the prophylactic skin treatment principle and or the reactive skin treatment. The prophylactic skin treatment regimen included the skin moisturizer daily, the hydrocortisone 1% daily, and doxycycline 100 milligrams twice a day, so 200 milligrams per day, and sunscreen with the SPF 15 or more before going outdoors. Next, please. And the primary endpoint of the STEP trial was the cumulative incidence of grade 2 or more of the skin toxicities in the patients in both groups, the prophylactic and the reactive skin treatment groups, during the 6-week period of treatment. And the secondary endpoints include the efficacy parameters, including the overall survival, PFS, the objective response rate, and also the quality of life of the patients and the safety, and also the time to first occurrence of the skin toxicities according to the grade. Next, please. So from this patient, regarding the patient disposition, the reason for ending the treatment in most patients were the disease progression, which was around 60% of the patients. And regarding the patients' characteristics, they were well balanced in both groups of the reactive skin treatment and the prophylactic skin treatment. Next, please. So for the primary endpoint, which was the incidence of grade 2 or more of skin toxicity during the skin treatment period, you could see from this table that the patients who underwent the prophylactic skin treatment had a lower grade 2 or the grade 3 skin toxicity compared to the reactive skin treatment group. And also on the last line of this table, the patient who underwent the prophylactic treatment regime had the less dose of panitumumab delay during the skin treatment period. Next, please. So one of the secondary endpoints was the time to first occurrence of the grade 2 or more of skin toxicities. And as being shown here, that the median time to first event of these grade 2 or more skin toxicities in the patients received the reactive skin treatment was 2.1 months, where in the prophylactic skin treatment group, this median time to first event was not reached. Next, please. In terms of the efficacy parameters of this regimen, this table showed that there was no statistically significant difference between both two groups. Next, please. And in addition to the skin toxicity treatment, when you look at the nausea and vomiting parameters or adverse events of the patients, you could see that although the skin-related toxicities in the patients undergoing the prophylactic skin treatment were less than the reactive skin treatment group. However, the nausea and vomiting adverse events in this prophylactic skin treatment group receiving the oral antibiotics higher than in the reactive skin treatment group. However, when looking at the diarrhea, neutropenia, and dehydration, hypomagnesemia, these adverse events were also lower in the prophylactic skin treatment group. Next, please. And so this STEP trial also looked at the quality of life of the patients by using this DLQI, stands for the Dermatology Life Quality Index score. And the mean quality of life score changed from the baseline till the week 3, where the patients firstly came in for assessment, was 1.3 points in the preemptive group compared to the 4.2 points score change in the reactive group. Next, please. So meaning that in terms of the quality of life, patients who underwent the preemptive skin management did better. So in conclusion, so this STEP trial showed that the prophylactic skin treatment regimen was well tolerated in patients receiving panitumumab, and which could decrease the grade 2 or more of skin toxicities compared to the reactive treatment group, and also show the improved or the less change in the quality of life. Next, please. So the last trial that I would like to share with you is just similar to this the STEP trial that I just mentioned earlier, but this J-STEP trial was done in the Japanese patients population. Next, please. So for this J-STEP study, it was the third-line regimen of panitumumab. So all patients received panitumumab every 2 weeks, and with the chemotherapy regimens which were chosen from the investigators or the investigators' choice. Patients also, again, the KRAS wild-type metastatic colorectal cancer with 2 prior chemotherapy regimens. So this is a third-line regimen were randomized to 1:1 ratio to receive the prophylactic or the reactive skin management. So in details, there were some differences in the agents given in the J-STEP compared to the STEP trial. So for the preemptive skin management they include the skin moisturizer, BID, not only daily, but twice a day, the topical steroid with the 0.5% hydrocortisone cream twice a day, and the the oral antibiotic was minocycline, 100 milligrams per day, and the sunscreen with the concentration of SPF 25 before the exposure to the sun. And then, next, please. So the primary endpoints were similar to the STEP trial, where the primary endpoint was the cumulative incidence of the grade 2 or more skin toxicities during the 6 weeks. And the other secondary endpoints were pretty the same as the STEP trial. Next, please. So as you could see here, so I forgot to mention that for this J-STEP trial, to decrease or to reduce the bias from the investigators, they also have the central review of the toxicity assessment by the central dermatologist. So from this table, the upper half were the results from the investigators' assessments, and the lower half from the central dermatologist review. And as you could see that the skin toxicity grade 2 or more were lower in patients receiving the preemptive skin management compared to the reactive skin treatment. However, the number of the patients developed the skin toxicities in the reactive skin treatment group, as being assessed by the investigators, were a bit higher than in the central review. Next, please. So this slide showed, in terms of the efficacy parameters, the efficacy parameters, including the median overall survival, PFS, or the overall response rate, were not statistically different in the two groups of the patients, where the preemptive skin treatment, the median OS was around 8 months compared to the 12 months number of the reactive skin treatment. This is the third line of treatment, and statistically they were not different. Next, please. So the table also shows the other than the skin and soft tissue toxicities, including the other aspects of the adverse events, which were pretty similar in both groups. Next, please. So in terms of quality of life, there were no statistical difference in the quality of life score at any of the time points between the two groups of the patients. Next, please. So for the J-step, which were done in the Japanese patients, and that could be some models or example of patients from the Asian population. The J-step results reinforce the step results regarding the efficacy of the preemptive skin treatment in this Japanese and also in Asian population. And the less toxicity of the skin were observed in the preemptive skin treatment group. Next, please. So in summary of my talk, the skin-related adverse reactions, either the skin itself or the soft tissue around the skin, are common with the EGFR inhibitors, including panitumumab. However, the majority of these reactions are in the mild to moderate in severity. But some patients might develop the severe or even life-threatening as well, although pretty rare. So it's important for the healthcare providers to be concerned of these common skin adverse events happening from the panitumumab treatment, and try to manage or to focus on the detection or using the preemptive skin strategy as another option. Next slide, which will be my last slide, please. Next slide, please. So where the potential benefits of this EGFR inhibitor-related skin toxicity management, including the panitumumab, includes to the limits the incidence of the severe symptoms, make the patients to tolerate the treatment better. So then decrease or minimize the need for the dose reduction or the early treatment discontinuation, improve the patient's quality of life. So the prophylactic or the preemptive, as opposed to the reactive studies, have been shown to reduce the impact of many adverse dermatological events. So therefore, this strategy, the prophylactic or the preemptive strategy, should be explained or should be introduced to the patients. But in some situations, if the preemptive skin toxicity management is not possible, the reactive treatment to take care or to manage the skin toxicity should be provided as soon as possible at the onset of symptoms. Thank you very much for your attention.
Thank you, Professor Pattarapim Sanpavirwong, for your informative information about the management of EGFR inhibitor skin reactions. So if anybody has some question, please send to us by typing to us. Our team will correct your answer, your question, and we will put in the session Q&A at the end of the second talk. Before Professor Julian Thiep give a talk, we would like you to answer some questions about the poll. Yes. So this is the first question. So please vote if you are ready. I just give a note that in this scenario, money is not the question, not the problem, right? Most of us choose the FOLFOX or KBOX plus anti-EGFR 77%. Some will also choose the anti-VEGF about 15%. Thank you for your vote. So we go to the second questions. This is about the second line setting. Please vote. Yeah, about 61% choose the chemotherapy plus anti-VEGF, but about 46 choose the chemotherapy plus anti-EGFR. 14% choose anti-EGFR alone, and some choose chemotherapy. Right, thank you. Go to the third question. This is about the third line. Third line treatment of RAS wild type. Please vote. Yes, very interesting answer. 38% choose the test 102. 27% choose the regorafenib, and 15% choose panitumumab, 8% choose cetuximab, and about 12% choose other. Right. Okay, go to the last question. Thank you. Okay, please vote. Okay. The management, 30% will re-biopsy for next-gen sequencing, but some 17% will do only for LAS and BLAF status. 26% do the LAS or BLAF liquid biopsy. And if LAS wild type positive, so if LAS wild type, they will consider anti-EGFR rechallenge in 48%. That's interesting. Right. Thank you for your answer. So I will go to the second famous speaker, Professor Julian Thiep. Professor Thiep received his, may I just introduce your CV a little bit? Professor Thiep received his MD and PhD qualification in gastroenterology and immunology from the University Pierre et Marie Curie, Paris, France. And then he currently holds the position of Head of Gastroenterology and Gastrointestinal Oncology Department at the Georges Pompidou European Hospital, Université de Paris, France. He is a regular reviewer of the famous Journal in Oncology, Lancet Oncology, JCO, Annals of Oncology, British Journal of Cancer, and European Journal of Cancer. Professor Thiep is a member of the ESMO, ASCO, FFCD, GERCO, SNFGE, and he is now a position in the Administrative Council or the Scientific Committee of ESMO, FFCD, and SNFGE. His main research topics are the non-metastatic and metastatic colon cancer and pancreatic cancer. He has involved in clinical trial and translation research, more than 10 in national and international phase 2 and 3 study. And also he's the author of 3 educational books. Professor Thiep will give us a talk on optimizing first-line treatment strategies for RAS wild-type metastatic colorectal cancer. Professor Thiep, please give the talk.
Thank you very much. So I will share my slide. No, this is not the good one, sorry. I have to share again. What is this? Sorry. Bah, ça marchait bien tout à l'heure. Okay, maybe now it's going to be better. Let's try that. Yes. Sorry. Good morning. Thank you very much for the nice invitation. Very happy to be with you all. Congratulations to Dr. Patratim for the very nice first talk on the management of toxicities, which is very important with anti-EGFR therapies, because when you manage well the toxicity, you can successfully use these drugs that are really improving survival in RAS wild-type patients. Here are my disclosures. So, first-line treatment, what is our objectives? So we have many objectives. Of course, we would like to improve patient survival as all the time in oncology, but we are also focusing on treatment tolerability, and that's why management of side effect is very important. And we have also the deal of tumor response, because colorectal cancer is, I would say, one of the best cancer for GI, because you know that when you are metastatic, if you can remove all the metastatic lesion, there is still a hope for cure for your patients. So response can be important, but response is not only important for secondary resection, it is also important if the patient is symptomatic, because it will improve the symptoms. And it's also important if there is a threatening lesion. For example, if you have a central lesion in the liver of 2 centimeters, and you know that if it goes to 3 centimeters, the bile duct will be completely obstructed. It is very important to avoid any progression and, I I would say, to induce response on this kind of lesion. So, of course, when we are on the potentially resectable disease or symptomatic disease, response will be even more important. If we are not on this disease, I would say that non-resectable disease, non-symptomatic disease, or fragile patient, we are going more to focus on how can we do the best survival with a good tolerability profile. The second point that is very important is knowing first line is important because first line is going to drive second line and third line choices. If you do one type of treatment in first line, you are not allowed to do all the types of treatment in second and third line. So there are treatment sequences in the continuum of care that are more beneficial to the patients than others. The second thing is also that in colon cancer, a lot of patients are moving from first line to second, third, and fourth line. But you can see that, for example, if we move for first line, where we approximately estimate that we are treating 80% of the patient, because we all forget the 20% of the patient that go very bad at diagnosis and die very, very quickly in our units. But if you take 100 patients with a first line, you will have 75% approximately going to second line, and less than 50% will move to fourth line, for example. So when you don't use something in first line, there is a risk that you don't use this drug never for 25% of the patients later on. And if it's a late line treatment, half of the patient will not be exposed to a potentially efficient drug. So very important also to give the most efficient treatment in first line, to my opinion. So first, we are going to discuss about tumor shrinkage and its importance in colorectal cancer. When the FIRE3 trial was reported, I remind you that FIRE3 was one of the first trials comparing anti-EGFR and anti-VEGF. There was a question because we found in this trial that PFS were more or less similar between the groups, but OS was in favor of anti-EGFR. Also earlier, with papers published in very prestigious journal, the concept of early tumor shrinkage and the concept of depth of response were developed. And what are these concepts? So the early tumor shrinkage is that you decrease, you shrink your tumor within 6 to 8 weeks, depending on the publication, and about 20 to 30% depending on the publication. So generally, we now move to a 30% or 20% decrease at 8 weeks because CT scans are generally done at 8 weeks in many countries. And the idea is that showing that if you have this kind of early tumor shrinkage, you may induce better outcome, and we are going to see how, because it may convert more often to resectable disease. It may impact directly prognosis, and it may also impact tumor-related symptoms, which is very intuitive and logical, but had to be proven in clinical trials. The second parameter is the depth of response. So is it the same if you decrease the size of your tumor of 28% or of 98%? Probably not, because the idea was that this tumor nadir will probably influence largely the time of death. Death is defined by the theoretical tumor load that your body is not able to assume. And then if you go with a deep response, it takes much more time to have this lethal tumor load. And that is why in these trials, when we had a similar PFS but different OS, this was explained by this kind of curves that are, of course, theoretical, but that can represent in a certain way what is happening with the tumor in our body when we have cancer. So what is the impact of ETS first on resection? Because theoretically, of course, if you have a good shrinkage, you should have better resection, but this is proven in the PRIME, the PEAK, and the PLANET trial that were meta-analyzed and published by myself and others in cancer research in clinical oncology. And you can see that in all trials, there was a trend for a better resection when ETS was over 30% and not if ETS was not present. So there is data showing that when you have a TS, you have more resection. There are also data that we published in the same journal showing that TPR is also important and that the vast majority of the resection occurred in patients with 53% to 100% reduction in tumor size, according to RECIST criteria, and almost no patient in the group with only 0 to 30%, I would say, tumor shrinkage. And I told you about OS, and you can see here the figure that is more complete. PFS can be very similar, but OS very different, assuming that you have a better deepness of response or depth of response, however you want to call it. And this was also linked to the outcome of the patient in the FIRE-3 trial, for example, here, where you see that the depth of response was 32% in FOLFIRI bevacizumab, as compared to almost 49% in FOLFIRI plus cetuximab, and that OS in these two groups were 26 months and 32 months. So there is a direct link between these different parameters in the FIRE-3 trial subgroup analysis. We also showed that with other groups treated with panitumumab here, and having survival that are completely different in patients with a good DPR here or poor DPR here. And you can see that the magnitude of the survival difference is very important between the best prognostic group and the worst prognostic group here. So another question and point that I mentioned is that when you shrink the tumor, you should decrease the symptom. Once again, this is very intuitive. Generally, when the tumor is symptomatic, if you reduce its volume, it should go to a better symptomatic control of your patient. So we have analyzed that by looking at weight loss, anemia, asthenia, and new opiate use from baseline. In PRIME, PEAK, and the 314 study, all with panitumumab, with a total of 659 patients. And what we have seen is that when you have an ETS of over 30%, you have a significant reduction of symptoms with all the symptoms that we are characterizing here. Of course, we don't have completely a completely symptomatic full screen because these were post-hoc analysis, and this has to be said. But as compared to the one with no ETS of 30%, these patients went really better on new opiate use, weight loss, anemia, asthenia, and ECOG-PS decline. So what about head-to-head randomized trial now comparing EGFR inhibitor and VEGF inhibitor? You know that currently we have 3 trials. A randomized phase 2 trial, PEAK, that tested FOLFOX-BEV versus FOLFOX-PANI. The FIRE-3 trial tested FOLFIRI-BEV versus FOLFIRI-CETUX. And the CLGB US trial that was testing FOLFOX or FOLFIRI-BEV versus FOLFOX or FOLFIRI-cetuximab, knowing that in the US, FOLFOX was used in more than 75% of the patient first line, and FOLFIRI was a minority of the patient. The problem of the US trial is that it is clearly the largest one. You can see the numbers here, more than 1,100 patients as compared to 600 and 300 approximately here. But the problem is that they were available to generate RAS data in only 48% of the patient. And at the end of the journey, the patient with a full RAS assessment in the US trial were less than 600 as in FIRE-3. So what we can see here is that if we go to PEAK, for example, we can go back to our ETS and DPR story, we can see that DPR and ETS were much better in the arm with panitumumab FOLFOX as compared to the arm of bevacizumab FOLFOX. This was also seen if you see like waterfall plots from the beginning here, if you have the depth of response assessed here, and you can see that the blue color is the difference between the chemo and the chemo bev and the chemo panitumumab here. So panitumumab adds this depth of response to what we can observe with a chemo bev control arm. And this was also shown in the same fashion where in FIRE-3 with a FOLFIRI backbone and not a FOLFOX backbone. So it's not the problem of what chemotherapy you use. It's really the addition of the anti-EGFR that is increasing the deepness of response that you can observe and all the surrogate outcome of this marker. For your information, there is still one trial ongoing that is going to compare anti-EGFR and anti-VEGF. It is the Japanese Paradigm trial. This is a trial that will randomize 1-to-1 patients to receive FOLFOX-PANI or FOLFOX-BEVA. But you can see that the number is very impressive as compared to what was done with PEAK. It's more than 800 patients. The limitation, of course, for us in Europe will be that is a full Japanese trial, as far as I know, but this will be very interesting to look at what happened in this population and also to look at probably translational research project on this large cohort to see if we can finally even better identify that what we are doing today, patients to receive an anti-EGFR or an anti-angiogenic drug in first line in the subgroup of RAS wild-type patients. So to summarize this first part, I would say that in patients receiving first-line treatment for RAS wild-type mCRC, ETS and depth of response are associated with secondary resectability. So if your goal is surgery, very important probably to use EGFR inhibitor. ETS may delay the onset of tumor-related symptom. Once again, response may improve symptom and important to show it, and it is shown now. ETS and DPR correlate with overall survival. So EGFR monoclonal antibody provide earlier shrinkage, more profound reduction of tumor size compared with placebo or bevacizumab, depending on the trials we have discussed. So once you have chosen your first line, there is a question about de-escalating treatment after a few months to improve your patient quality of life. We know from Emery de Gramont and the GERCOR group from the 2000 that continuing FOLFOX until toxicity or having a stop-and-go strategy is approximately equivalent with a better quality of life and less toxicity with the stop-and-go strategy. We know also from the same group with the OPTIMOX 2 trial that a complete treatment stop may be deleterious in some patients and that we cannot propose chemotherapy holiday to all comers in colorectal cancer after 3 to 6 months of induction therapy. So during the last 2 decades, many maintenance trials were ongoing. The first ones tested, for example, bevacizumab alone with the SAC trial and others, and the PRODIGE 9 trial in France, showing that bevacizumab alone does not do really better than complete treatment stop. And I told you that complete treatment stop can be deleterious for some patients, so we don't have to do complete treatment stop in all comers. We moved then progressively to capecitabine or 5-FU and bevacizumab as a standard option because it is quite well tolerated. It allows the patient to come only every 3 weeks to the day hospital for having the bevacizumab injection. But if you look at all the Dutch, US, Netherlands, and other trials like PRODIGE 9 also in France, testing this kind of strategy, there is never a trial in capecitabine and bevacizumab. So we don't know if bevacizumab is really important in the maintenance today. There are 2 trials ongoing, one in France, one in the US, to see if 5-FU is doing as good as 5-FU bevacizumab or capecitabine bevacizumab. But this trial will not be completed after 1 or 2 years from now. What about anti-EGFR? Anti-EGFR were very late on the maintenance story. And I think that panitumumab has now a lot of evidence that has been brought by new trials that were launched a few years ago. And we have a lot of data that are very interesting with anti-EGFR as maintenance therapy. I will talk about 3 trials, all with panitumumab. You can see that the SAPHIR first trial tested a stop-and-go strategy. You stop oxaliplatin or you continue oxaliplatin. So it's like the OPTIMOX 1 trial from de Gramont 20 years ago, but with a targeted agent that is panitumumab for RAS wild-type patient. And here we will see the results, but the results are that globally we can stop oxaliplatin as previously without being deleterious for the patient. The second trial, Valentino, is this time testing panitumumab plus 5-FU as maintenance, so what was validated by SAPHIR, versus panitumumab alone. And this Valentino trial is going to show, we are going to see briefly the results, that panitumumab plus 5-FU does better than panitumumab. So panitumumab is not inefficient, but the combo of 5-FU and panitumumab looks better. But here we are still lacking one answer. Is panitumumab 5-FU doing better than 5-FU? And this is the Panama trial that has been presented at ASCO last month. So if we go back to the results, in SAPHIR, when we stop oxaliplatin, what we can see is that the arm with panitumumab and oxaliplatin stop here does as good and even a little bit better than the arm with continuing FOLFOX-PANI indefinitely until limiting toxicities. So this is validated. Valentino here, what we can see is that panitumumab has a good 10-month PFS rate of 50%, but adding 5-FU looks a bit better with a 60% control at 10 months, which was the primary endpoint of this trial. Response rates are the same, by the way, here during that period of time, but this is also from the beginning. And in terms of a side effect, adding 5-FU is adding a bit of a side effect, of course. The last one, Panama, presented very recently by my friend Dominique Modeste from La Charité at Berlin in Germany, compared 5-FU this time and 5-FU panitumumab. So this is the last stone of the edifice that was missing, and now we have the answer. And what has been reported is first that when you continue with panitumumab and 5-FU, you do better than 5-FU in terms of response rate, 40% versus 26% during the time of maintenance. That PFS is better when you do the combo therapy as compared to 5-FU alone, and that panitumumab is really adding something as a maintenance therapy to 5-FU alone. Tolerability was quite good in this trial. What they have observed in OS is that there is a trend with OS moving of 3 months, which is not so bad. This was almost the results from TRIBE-1 trial with the triplet chemotherapy, moving from 25 to 28 months. So it's clinically relevant, but not statistically significant, probably due to a lack of power, because you can see that the limited sample of this trial is not powered for estimating clearly OS in metastatic colorectal cancer. However, the study is positive, and panitumumab and 5-FU can be considered as a standard maintenance therapy. What they also reported during Panama is that when you move to panitumumab 5-FU and not to 5-FU alone, people were not reintroducing very often FOLFOX panitumumab at progression, as mentioned by the protocol, and that the results with the reintroduction of FOLFOX panitumumab, so by the way, the reintroduction here of only oxaliplatin didn't give very nice results, and that they advised that we can switch after this de-escalation, not to restart the same first-line treatment, but to switch to FOLFIRI bevacizumab, for example, in these patients when they progress. There is another setting that is very important, for which we don't have currently results, but trials are ongoing. This setting is the setting of loops of reintroduction of anti-EGFR. We have learned from the literature that anti-EGFR do put a selection pressure on tumor clones, and that during anti-EGFR treatment, we can see the emergence of RAS mutations, but also sometimes PI3K, HER2, and other mutation on the MAP kinase pathway or on the alternate pathway of PI3K, AKT, and mTOR. So we know that this treatment can generate resistance, molecular resistance. So one idea would be not to continue them as long as we can,